them at the end.
All right.
Okay, well, I'm going to just formally start us off and say good evening to everyone who is joining us for our 7 Sterling webinar series, designed to give you, healthcare providers across specialties, pearls to help you feel more confident in supporting your patients with perinatal mood and anxiety disorders. My name is Nazanin Homofar, and I'm a practicing OB-GYN in Northern Virginia and the medical director at 7 Sterling. 7 Sterling is a maternal mental health clinic that treats women experiencing anxiety, depression, and trauma throughout fertility challenges, pregnancy loss and miscarriage, abortion, postpartum, and early parenthood. We are excited to announce that we now accept Anthem insurance across Maryland, DC, and Virginia, and we are thrilled to become as accessible as possible to your patients. You'll be the first to know as we bring on more major payers throughout the year. And I'm thrilled to be joined by Dr. Crystal Clark, an associate professor of psychiatry and behavioral health sciences and in obstetrics and gynecology at Northwestern Feinberg School of Medicine, as we talk about new advances in pharmacologic therapies for PMADs. She specializes in mood and anxiety disorders and is an expert in the treatment of women's mental health across the reproductive lifespan. For those of you who read the Green Journal, she recently had a paper published, I believe it was in the last month's issue, with her research. She has dedicated her career to reproductive psychiatry and the advancement of maternal mental health. She's a researcher, educator, clinician, and thought leader, and we're very lucky to have her as an advisor to 7 Sterling. So welcome, Dr. Clark.
Thank you for having me. I always look forward to these discussions, and I'm looking forward to this topic tonight.
Me too. I just keep adding to my knowledge, and I feel so lucky to be able to do this with you. Previously, you had walked us through a review of various perinatal mood and anxiety disorders. We also did a webinar on how to prescribe 3 to 4 SSRIs for depression and anxiety. And in the past year, we've heard more about updates of antidepressants available for patients with severe postpartum depression. Brexanolone, you're going to have to correct me because I was going to ask you this before we started, but is it Brexanolone? Is that how you pronounce it?
Brexanolone.
Brexanolone, sorry. It's like when patients of mine are trying to say misoprostol or something like that and they get it totally wrong. So I put Brexanolone, brand name Zulresso. Did I say that correctly?
Yeah.
Was approved by the FDA in March of 2019 for IV use, and the first drug approved specifically for postpartum depression. Zuranolone, did I say that correctly?
Yes.
Okay, is an investigational 2-week, once daily oral drug being developed for major depressive disorder and postpartum depression by Sage Therapeutics. The results of the phase 3 study of the drug were recently released and overall positive. So I just wanted to give everyone the 2 drugs that we're really going to be focusing on, but can you tell us more about these medications, how they're administered, how they should be used?
Yeah, absolutely. So Brexanolone, what was exciting about this drug, sorry for the ringing, but what's exciting about this drug when it came out was that it's an infusion. And I don't know that people care so much about being an infusion as much as they cared about the fact that it's supposed to get an effect within 60 hours. It's a very different modality than we've had any other treatment for postpartum depression, which has been exclusively limited to psychotherapy and antidepressant drugs such as SSRIs or selective serotonin reuptake inhibitors. So this is the first to be an infusion, to only be needing, only be administered over the first 60 hours of the onset of the illness or whenever a patient presents, and targeting a different pathway, being the GABA A receptors, which is different from focusing on serotonin, increasing the serotonin levels specifically or directly. The Zuranolone is also very different. It's a 2-week, once-a-day drug. So compared to what we expect with SSRIs, where you're giving this drug over months and usually at least for a duration of 6 months to a year, this drug only is given over a 2-week period once a day.
And so then presumably you would be treated. We'll get into this in the next question, but then after 2 weeks, would you continue another medication, or you would be well enough, presumably, that you wouldn't need anything else?
So presumably you'd be well enough so that you didn't need anything else. Imagine that.
Wow. So
Yes.
tell us a little bit about the studies. There was the SKYLARK phase 3 study that was recently published. Could you review some of the findings that was specifically for zuranolone?
Yeah, so for zuranolone, what they found was there was actually pretty good evidence just within a few days of this drug being taken that scores on the Hamilton D, which is a depression scale, were reduced. So symptoms, meaning the symptoms were reduced in as early as 3 days in the study. But by the end of the study, after that 2 week period in which the drug was taken once a day, you had people showing significant improvement in their symptoms, indicating either 50% improvement or full remission of symptoms after a 2 week period. So that was pretty phenomenal to the investigators for this drug. And that's what's made this drug in particular very exciting with its upcoming release.
Anything we should, the first thing that I thought of when I heard you say they use the Hamilton D, I'm not familiar with that. I'm sure as a psychiatrist you are. Is there anything to be said about using the Hamilton D versus something that we're more familiar with for postpartum depression, like the Edinburgh postpartum depression scale or the PHQ-9?
Yeah, great question. So there hasn't been any like head-to-head study to say, this is how we would expect this to translate to the Edinburgh or the PHQ-9. However, we would expect that at minimum, just for everyone's, to keep this somewhat simplistic. So for everyone's purposes here, the takeaway would be that with the PHQ-9 or the EPDS, you would expect that if a patient presents with symptoms that are indicative of them having a depression on either one of those scales, or high likelihood, because they're not actually diagnostic scales, they're screens. So high likelihood of having a depression, you would expect that they would have a significant decrease in that score. So say the score was 11 on the EPDS, we're expecting that maybe it decreases as much as 50%, being 5 or 6 points off of that scale at the next time you see that patient once they've completed this treatment. So we're expecting a significant improvement such that they are not likely to be screening high enough to have a depressive illness at the time that they complete the treatment.
Amazing. And how about Brexanolone? Do anything from the studies that you could share with us?
Yeah, same. So this one is also, pretty phenomenal in that within 60 hours, you're seeing a significant decrease in symptoms for patients who have received this drug. And similarly to zuranolone, you're seeing a significant drop from where they were. So anywhere to 40 to 60% is what we were seeing with the patients, most of the patients.
Who would how would this compare, either of these medications, to SSRIs or psychotherapy used to treat postpartum depression?
Yeah, so it's so important that people take away a few things. I think when we think about these new drugs, we're very excited about their release and the fact that they offer such a quick response to, or really improvement to the illness. But let's just, number one, say that Brexanolone is not offered everywhere. In fact, I don't even know. There's like a list of places, because that's how rare it is to find it. A lot of hospitals don't have the space or the resources to administer this drug. You must have a room for the woman to get IV drug, nursing assistants, a doctor who can check in on them, all of these things, and plus pay for the drug. And although Sage Therapeutics, who has created this drug, says there's lots of lots of help they can provide. I can tell you it's been hard to get this for patients in many places. So uh, we'll have to see how accessible Zuranolone is. Hopefully it will be more accessible because you don't have to have all those resources. But I bring that up because at the end of the day, I think we're going to be left for a little while, at least, depending on our tried and true, which is antidepressants and psychotherapy. And that's not necessarily a bad thing. I want people to appreciate that with antidepressants, we have seen more so anecdotally, it's not, there needs to be a head-to-head trial. I think that would be great to see in the future of SSRIs versus Zuranolone, for instance. But we do see responses pretty quickly with those who have a hormonally precipitated depressive onset or anxiety onset. So what I mean by that is that I can give Zoloft and within a week have a patient who's already telling me that they have improvements. We see something different than what we see in a patient who is not in a perinatal state or a hormonally dysregulated state who comes in needing an antidepressant and might not respond for 4 to 6 weeks, which is what you typically hear, right? But in these patients, my perinatal patients, many of them will respond pretty quickly. So I want people to not get discouraged, like, oh gosh, I can't get my patient Brexanolone or Zuranolone.
Yeah.
You can still get that SSRI and get a pretty quick response for those, again, if this is a hormonally triggered mood episode. Maybe not quite 60 hours, because that's something very unique and novel.
But I think even though you and I have discussed this before, it's a point that I have to keep reminding myself, and something that I think in my counseling for patients is really useful to let them know that when they start something in the postpartum period or even perinatally, like an SSRI, they should see some improvement in the first 1 to 2 weeks.
Yes.
And so keeping that in mind and to help reassure the patient is really important. You mentioned a little bit of, the challenges with Brexanolone and what is required for administration. So who would be the ideal candidates for it? And is this something you would anticipate ahead of time, or is it a medication that you would think about giving only after you've diagnosed very severe symptoms? Like, how would we think about this medication for our population?
Yeah, so definitely thinking about that moderate to severe patient or moderate to severe symptoms that the patient is presenting with for depression and more depression than anxiety or other illnesses. So, because that's what's been indicated for, specifically postpartum depression. But I'm thinking of the patient who honestly is more resourced and can be away from their child for 3 days. Someone who has a partner who can be taking care of the baby for that 60 hours. And it's not going to be exactly 60 hours. We got to admit the patient, you got to get discharged from the hospital, all the things. So at least 3 days. So I think those are two major things. And then just having being in a facility that can support the Brexanolone administration are very important. But in terms of just the patient characteristics, someone who has moderate to severe symptoms, I think is an ideal candidate.
And presumably this is a person that you're identifying postpartum, maybe maybe at 2 weeks if you're lucky to see them there, but most likely 6 weeks unless they're calling you and telling you that they're concerning. So
yeah, and absolutely. And I apologize because I don't know if I didn't think about this and thinking about our talk today, but I don't know that anyone has looked way out yet. I don't believe there are any studies like looking further out into, is the response to the drug the same, whether that onset is at 6 months or 8 months or 12 months. I think we have to remember that first year postpartum, the illness can onset at any time during that year. But of course, for the purposes of OB-GYNs, you're not likely to see that patient after that 6-week mark. So definitely, if you see someone at 6 weeks who has significant symptoms, they would be a great candidate for Brexanolone or Zuranolone.
in the future when that's
Yeah, in
released.
the future. Yeah.
And with Brexanolone, there is, you alluded to this, that it's only available through a restricted program called the Zulresso REMS program, and it
Mhm.
requires that the drug is administered by a healthcare provider in a certified healthcare facility. Do you have a sense of how many facilities exist? Like, have you been able to get this drug at Northwestern?
No, have not been, and it's not because patients haven't asked. I do not have a good sense of how many exist. I'm happy that we can definitely post that. I can get that information, but it's not many, not many at all. There, I'm just thinking about Illinois, the state that I'm in, and I can't think of any place that has this drug offered. I do know of some places around the country, and most of them, again, either have a perinatal women's mental health unit, or or have set up some particular space with their OB/GYN department. But it's a lot of administrative hurdles
Or
to
I
jump in
imagine.
terms of space. I mean, things we don't think about. It's like, okay, well, who's paying for this space? Is it OB/GYN or psychiatry?
Right,
Who's
right.
paying for the nurse? Who's gonna who's gonna support the time required to monitor the patients during the procedure and afterwards? And all of those things have to be in place in addition to the patients having the insurance that will cover this, or the support from Sage Therapeutics that will cover this.
I think, and for me, that's just a reminder too, if I get asked, if we have savvy patients that are asking about it, to let them
Mhm.
know that it is logistically very challenging. I think I remember speaking to Dr. Payne at UVA, who I know you're
Mhm.
friends with, and one of her goals was trying to bring it to UVA, and I'd have to
Mhm.
ask her how, if she's been
How's
successful
it
with it.
going?
And otherwise, I don't know of where else in Virginia would take the initiative
Yeah,
to do it, because it does require a lot of logistical um,
yeah,
to be done.
yeah. And I won't be surprised if it starts being administered, outpatient or something. I don't know that that's the best thing. We see this with ketamine. And when I was a part of the early ketamine trials, the ketamine infusion trials to be specific, the we had to have an anesthesiologist, standing by to make sure everything was okay. To my knowledge, a lot of these places that have popped up that provide ketamine infusions, they don't have an anesthesiologist, or they're doing this all by themselves, and that might be okay. I don't know, but it's not what the standards have been in terms of that administration. So, hoping that the hospitals will eventually support more and more the administration and the resources and space needed for administration of this drug, and that it doesn't become something that outpatient providers are starting to do because they have no other way to get the drug to the patient.
Yeah, absolutely. I mean, I think for me too, I'm like, well, we have to screen to be able to identify, and we're
Right,
still struggling in parts of the country to screen people. So
right. Yes,
it's going to be,
start with the basics.
yeah. Can you use Brexanolone for postpartum anxiety or bipolar depression?
It has not been studied in either postpartum anxiety or bipolar depression. I I don't know if there are any studies on the horizon. I imagine with the anxiety might be closer to there being more thoughts about that than for bipolar depression, although there has been lots of talk about, might we try some trials with patients who have bipolar disorder? But of course, everyone's always a little tentative, I should say, about the possibility of creating a manic episode or precipitating a manic episode in a patient with bipolar disorder who
Mhm.
starts off depressed. So we'll see what happens. I'm hoping that we'll at least try it to see if it could be helpful, given that it's a different mechanism.
And I know bipolar disorder and its study in pregnancy is one of your research interests and areas of passion, and something that we'll hopefully talk about in the future too, because it is, I don't think, well understood or screened for in the pregnant population. So we
Yes.
will hope that conversation one day.
Yeah.
Um, You alluded to this when you were talking about the need for monitoring patients, but what are the side effects of these medications, specifically Brexanolone, and what, how would you counsel the patient on its use?
Yeah. So we're definitely still learning in terms of zuranolone, but for brexanolone, some of the main side effects being sedation, dizziness, um, and so it's, you're in the hospital for the 60-hour infusion, so there shouldn't be a lot of monitoring required or adverse effects after you leave the hospital, but in the hospital, that's why the monitoring is required and prior to the discharge from the hospital because of the, could also have headaches, but dizziness, sedation, which can be difficult when you're trying to take care of a newborn, also driving, all of those things. So, but typically when people are leaving the hospital, to my knowledge, there hasn't been much report on like long lasting, weeks out side effects of this drug.
And so if you were seeing a patient and you had access to the medication, to Brexanolone, how would you counsel the patient on its use versus, let's say, an SSRI?
Yeah, I would say that, we're always looking to find ways to reduce the suffering and the duration of suffering, specifically for patients who have just given birth and want to just be home, spending time with their baby and not worried about like just feeling good enough to take care of their child. So what I like about Brexanolone is the um, 60-hour limitation in terms of, okay, this is the full treatment. And now, ideally, if it works, okay, we're done. You can get back to living your life, which is a little shorter than, like I said, what would be going on with the antidepressant. It will take at least a week to start to see some improvements. The other thing that I think patients love about the medication is that, again, after 60 hours, theoretically, they're done. Now, I'm not aware of any studies yet where they followed the patient to a year out to see what happens.
Yeah,
So we um, we have to see.
right,
But the thought is that the patient shouldn't need anything else. And of course, there's so much more research to be done. What patients are we talking about? We're talking about maybe the patient who just had their first onset postpartum, may not be necessarily the patient who has a history of chronic depression, who has an exacerbation in terms of the perinatal period. But
mhm,
I think we're talking more about those patients who this is their first time ever having an episode, was triggered by postpartum. Again, that hormonal association. They get the 60-hour infusion, and ideally, the thought is that they don't need to come back for any more treatment. And I think that is how I would be talking to the patient, and the type of patient I would trigger, just kind of going back to who would be the ideal candidate. It would be that
right.
person with a first onset postpartum.
And that makes sense. I mean, it would be appealing. It's like, do I take an SSRI for
Right.
3 to 6 months,
Mhm.
maybe longer, or is there this wonder drug,
Yeah.
if I can access it, that will cure me?
Right.
And I think yeah, we have to see with the studies before we get really excited,
Yeah.
uh, how long of an effect
Yeah.
it can have.
Yeah.
And presumably, I don't know if this was studied with Zuranolone, but it would be the same, right? That you
Mhm.
take it for 2 weeks and then you're done.
Right. Yeah. And it has that. Yeah. Going further out into the first year postpartum, at least that data hasn't been released yet.
Mhm.
So we'll see, and I'm not sure to what degree it's been studied, to be honest. But yeah, similarly, we want to know, well, what happens 8 months out, 2 years later? Are
Right.
these women
Could you even repeat it?
right? Would you repeat it? All of that, more to come. Hopefully those studies will be done. But I think right now they're just focused on getting it released
Mhm.
for that initial onset of symptoms and seeing and then starting to layer the studies and looking at, well, how long does it last? Do we repeat dosing? Who does it last for? What
Mhm.
types of patients are the most ideal candidates?
That's great. Thank you. I know I learned a lot. We have a few minutes and I wanted to open it up for our attendees to see if anyone had any questions um, that weren't answered or anything else that came up while we're waiting to see. Do we have any data about the safety of the lactation safety for these medications? Do you know?
Yeah, I wish. One of my things I harp on my soapbox. I'm like, all these medications need to have more data for breastfeeding. So, initially, as these studies roll out, that's kind of the last thing they look at. I mean, they're starting to look at it more, so we're thankful for that. But it's not usually part of the initial studies because of the concern that there's some transfer, and then of course you're like, well, but the woman's likely not going to stop, breastfeeding. so, so yeah, so verdict's still out on that.
Got you. Thank you. Well, um, I want to thank you again for all of this information, Dr. Clark, for taking those studies, distilling it down for us to these talking points for our general knowledge so that we know how to answer questions from patients. To the providers who joined us today, we hope you found these 30 minutes engaging and informative. At Seven Starling, we are committed to providing the full spectrum of women's mental health and would love to support you and your patients. So please check out our website at sevenstarling.com to learn more about how we may help you in your own practice. If you like this webinar, you can subscribe to our newsletter so we can keep you informed about future events. Dr. Clark, I could stay on and talk to you all day, but I know we both have busy lives. Thank you. I truly appreciate it.
All right, I look forward to the next one. Have a wonderful evening, and thanks for having me.
Absolutely. You too. Have a good night, everyone. Bye.
Bye.